Went on to explain that her practice had just gone through an audit. And for those who know how these audits can be at her state, and she said, the auditors seem to be enjoying pointing out insignificant deficiencies in my practice. She noted one that although her staff all have name tags, they didn't have their appropriate title on that, so her practice got dinged. But you see, she practices in a rural community. She says, my staff know all the people that come into our office, so we never thought that was an issue. Unfortunately, she concludes her email and says, sadly, I would not encourage any young person to go into medicine. No one cares if you're a compassionate, caring physician. They only care that your charts are documented well. And unfortunately, stories like that we're hearing more and more often, where physicians are sort of burnt out and frustrated. Now, it's not a majority of physicians, but it is a growing minority of physicians that say they wouldn't recommend the profession to their children, which for us is very troubling. But when I present this to audiences like the one here today, I always get a lot of nodding heads that this is the right area, this is something we should be focused on. And even those physicians who say they're satisfied with their careers can list a long list of things that are more burdensome today than they should be to provide high-quality care. Unfortunately, there are times when I present to non-physician audiences. And folks who, even though work in healthcare, are not physicians, sometimes ask, why is the AMA focused on physician satisfaction? Isn't that self-serving for the physician organization to be looking at that? And the response I get time and time again is that, the AMA, you should be focused on patient satisfaction, not physician satisfaction. And that always makes me pause, because people don't understand that there's a correlation between physician satisfaction and patient satisfaction. If we want high patient satisfaction, we need to have a highly satisfied professional physician workforce. So we work on professional satisfaction for physicians because it is about taking care of quality, providing high quality patient care. And it's so proven in almost every other industry that there's a correlation between employee satisfaction and the customers they serve, but somehow we want to ignore the correlation between physician satisfaction and the patients they care for. And in some studies, it shows that it's not only good for customer care. A study by Professor Alex Edmonds at Wharton did a study of for-profit companies on the stock market and found that those who had higher employee satisfaction had more than double the returns than their peers in the stock market. So it's good for business. But we somehow ignore that for physicians, and we cannot do that any longer. So what are we actually doing? Or how are we doing this? Our goal is to identify and support and grow models of care delivery and payment that sustain physician practices and promote professional satisfaction and lead to the improvements in the cost and quality of American healthcare. So what are we doing? Well, that's a work in progress, and that's what I'm here to talk to you about today. The first thing we did is we went out and studied all the literature around physician satisfaction. We found sort of two things came about. One was that a lot of the studies around physician satisfaction were done in the 1990s when the issues around managed care. And that the more recent studies we saw on professional satisfaction were studies that, if you really peeled back the onion and looked at the methods, had some questionable methods. 1% response rates in surveys. So we didn't feel comfortable about that sort of research body as something we would use as a basis for our strategic focus area. So I was described, we went out and partnered with RAND, a reputable research firm, to do a study around professional satisfaction. And RAND did, for us, a mixed method study. They went out to 30 practices in 6 states. A mix of states, Colorado, Texas, Massachusetts, North Carolina, Wisconsin, and Washington State. And they went to 30 different practices, and led by a physician-led research team. The research team was actually led by 2 practicing physicians. They went out and interviewed 220 individuals. And then we went and surveyed the rest of the practices and surveyed over 650 additional individuals and had about a 65% response rate. So that helped us pull together a study that we released last October that has gained tremendous media attention. It was featured in the New York Times, U.S. News World Report. Many of the state medical society associations did stories on the report. And the report was called Factors Affecting Physician Professional Satisfaction and Their Implications for Patient Care, Health Systems, and Health Policy. Now, you can download the study free from RAND. You can go to RAND website, type in, you can get the study for free. I will tell you right now, it's about 150 pages, so you probably don't need to read the whole thing. These are the chapters that are that the study breaks out the topics, and I wanted to spend a little time going through some of the key findings so that you didn't need to read the entire study. Two things really came and jumped out of the study, and the first one I couldn't be more excited about is that what makes physicians satisfied at the end of the day is when they feel that they were able to provide high-quality patient care. And I think that's something that the profession can really rally behind. And on the flip side, what's dissatisfying is when physicians feel like there were barriers to providing high-quality care. And I think that says a real good summary of the entire report. I mean, physicians want to provide high-quality care for their patients. And unfortunately, we've created a system that creates lots of barriers to doing that. And those are the things that create the greatest frustration. And the biggest one that came out was chapter number 2, which was around electronic health records. And I'll talk a little bit more about what we found with that topic. So, as I said, perceived barriers to providing high-quality care, lower dissatisfaction, electronic health records, and I'll dig deeper into these first two. Lack of collegiality amongst physicians and amongst other support staff was an issue that led to dissatisfaction. For primary care physicians, they said, feeling subservient to other specialties was a level of dissatisfaction. Lack of faith in practice leadership was an issue. So if physicians felt that practice leadership did not have the same values as them, they found that dissatisfying. Or the hospital had different values than they thought. Worries about practice sustainability as a business. As we transform and move into new payment models, what does it mean for the practice and making it sustainable? Worries about work volume, too little or too much. For primary care physicians, the issues around too much work. But as we heard this morning in some of our first presentation, the actual number of utilization in healthcare is going down. And for some specialties, those concerned in particular markets that they're seeing too little work or worried that there wouldn't be enough patient visits for certain specialties in their market to sustain their practice. So that becomes income preservation becomes a challenge. And then regulatory burdens. And what the thing about regulatory burdens is that it's a lot of little things add up. It's not any one in and of itself, although the most, the study was done in the field in 2013, the most common regulatory issue that was mentioned was meaningful use. What we see was that lots of little things add up and make it frustrating. But I want to spend a minute going a little bit deeper into the first two topics. The first one is around quality of care. So what we hear is that when physicians feel good about the care they perceive that they're providing for their patients, they feel good about it. Here's a quote from our study. There's something so satisfying and proud about doing 100% of what we believe in. I think everyone here believes, myself included, that we really do a superior job. So this feeling of pride about providing high quality care. On the flip side, another primary care physician wrote about the unrelenting pace of patient care, with 15 and 20-minute visits for people who avoid seeking health care until they have serious problems. Not only leads to innumerable long hours, but it was also an error waiting to happen. So this sort of pace of work we hear about. What I think is important is we hear physicians talking about these concerns that they don't feel like they're providing high-quality care. If I'm a hospital administrator or I'm leading a practice, those are the types of areas that I'm going to go look for quality improvement activities. Well, not all things that can make physicians more satisfied. The ones that are taking away from providing high-quality patient care should be areas that we're focusing on. I'll spend a little bit more time as well talking about electronic health records. And this is sort of a funny story. So in classic sort of research design, and what you do in research is you leverage previously validated survey instruments. And if you're going to leverage previously validated survey instruments around physician opinions and physician satisfaction, they may be 4 or 5 or 6 years old. Unfortunately, surveys about physician satisfaction that are 4 or 5 or 6 years old probably don't have a lot of questions around electronic health records in them. So shame on us, when we actually went out to pilot, we didn't have a single question about electronic health records in our survey. But fortunately, we piloted it, and during the qualitative interviews, we found that physicians could spend 10 or 15 minutes talking about one issue that bothered them the most, and it was their electronic health record. So we actually then went and added an entire page of questions in our survey when we launched it for the full survey. Which is funny too, because when these findings came out, we got calls from a lot of the electronic health record vendors saying that we're on a witch hunt for EHRs. And I said, actually, we didn't even put EHR questions in the survey. It was that when we interviewed physicians, it was the thing that they brought up more often than not. Now let's be clear. There are a lot of positives for electronic health records. And the majority of the physicians in our survey do not say they want to go back to paper. I think people are optimistic about the future of technology, and we need to support that. And some of the things that they see work are, better access to patient data, improve some aspects of quality, better communication within the practice. And here's a quote. With hundreds of docs, I'm able to look at anybody's note, anytime, on any patient that I'm interested in, or that has seen me for something. I think the EHR just erases a lot of potential for medical errors and so forth, because everything is clearly documented and there's no handwriting issues. So there are positives with electronic health records. On the flip side, we heard many negatives. One is about time-consuming data entry. That physicians are feeling like now they're acting more as clerks, they're acting more as typists, they're spending more time putting data in the electronic health record than they are spending time with their patients. Furthermore, they mentioned that doesn't fit their clinical workflow process. It interferes with face-to-face patient communication, particularly for those physicians who try to do their documentation with the patient in the room. There was a lack of health information exchange, and maybe some naive physicians who thought they could buy a particular brand of electronic health record that the hospital and their community used, and they thought there would be some communication between the two. We quickly found that they had no communication between their electronic health record and the one in the hospital, even though they're the same brand product. Information overload. And this one was quite interesting. You actually can get too much information as physicians. You can provide too many things in your inbox, and it's hard to, and a lot of electronic health records don't let you prioritize that information. And what's important and what's not important. Expensive practice finances, not only in purchasing the electronic health records, but we heard about the maintenance costs for electronic health records. For many practices, was more than they thought they would be to maintain their electronic health record. Inefficient and less fulfilling work content, so physicians are feeling that time they're spending on their EHR is not a good use of their time. It's not a satisfier. And I think the most concerning is that template-based notes are degrading the quality of clinical documentation. We heard a lot of the copying, pasting, or filling out the forms, and it's really hard to understand what's actually useful in the medical record. And I think that's a troubling activity that we need to make sure we fix. And one of my favorite quotes from the entire study is a physician who says, every screen's got 50 different things, that are changing. It slows me down. So I do some of my charting at night. The problem is I'm spending more hours doing it than I did before. I think it's probably a common theme. People are spending more time doing charting. So I use Dragon, and if you're not familiar with it, it's a voice dictation software product. And he says, you've got to be careful, because I said, the patient's prostate is bothering him, and it turned out the patient's prostitute is bothering him. You've got to be careful, because you can go to court with that, he knows. I also know you need to code those differently. And I think ICD-10 will take care of that. So this was a study we did, and it had a number of conclusions. And there were conclusions about activities and things that physicians could try to take on within their own practices. And there was a lot of things that were beyond the reach of any one physician practice that they should be that they can tackle. But as an organization that represents physicians, we thought we should be taking on both of these activities. And what we hear is this time pressure detracting from the care experience. So many things that are on physicians' plate keep them from doing what they actually want to do, which is spend time caring for patients. So how do we remove those activities, those barriers? Lost a sense of control over day-to-day decisions. feeling like they've lost some autonomy and control over their work environment, loss of collegiality. And we've heard a number of stories, particularly for primary care physicians who are no longer rotating within the hospital. You know, that time in the hospital lounge where they could spend time with their peers, they're not having that, so they're feeling the sense of isolation. We're hearing another story of a practice who had sold their practice, but when they had owned it, they had had these business meetings, those opportunities to come together, but now that they sold their practice, those meetings no longer existed, and there was not time to spend with their peers and do that networking, which makes it important for events like this, this event, where physicians can come together and have some opportunities to network and help get over those feelings of isolation that can sometimes happen within the practice. And probably, you know, this last one around the internal physician issues is stress due to change. And that change, the rapid pace of change we're seeing in healthcare is only going to increase. Outside of the physician practice, there are sort of large health system issues. One is the EHR problem. Some of that will get fixed naturally as technology improves, but we also need to make sure we're supporting that through appropriate government regulation. And the AMA has been very active in trying to get some pushback on the meaningful use program, getting more flexibility in how they track that. And that just ties to the second one, the cumulative regulatory burden. We've got to do something to manage that. And the government needs to understand what is the cost of adding an additional regulation. When physicians and their staff and the nurses are spending time doing that, how many minutes does that add up to take away from available patient visits? Relationships with hospitals and health systems. You know, we heard this morning that maybe the Cold War, that the freeze was thawing, I think was the quote on the slide, and the need for additional payment methodologies. So, you know, as you read the study, I think many of you might find and see some of these findings up here today is that, you know, you probably say, Michael, I could have wrote that study. That seems like a pretty common stuff. And in many cases, the topics and the issues that the RAND study identified are issues that are pretty common. And this is a pretty highly informed group here. We could have grabbed any table, sit down, and probably would have come up with 85, 90, 95% of what was in this report. But for an issue around professional satisfaction for physicians, something that has been sort of ignored in healthcare, it was important for us to have a body of knowledge that we could work with that was done by a reputable research partner. So this wasn't anecdotes that we were talking about. This was actual research done. And it's really been powerful for us to really raise the dialogue around this issue with regulators and with others involved in working with physicians, because we can't ignore physician satisfaction any longer. Hospitals talk about, well, we do track our patient satisfaction. We have the scores, and we do things around nursing satisfaction. And actually, we do satisfaction studies for every other employee within the health system, but somehow we're ignoring the physicians, and that's got to stop. And I say the RAND study for us has been very tremendous. And we've actually, I got from one of my colleagues in our DC office was in a hearing and actually heard some regulators actually referencing our study. So we know that it's getting into the halls that it needs to get into to influence our healthcare system. So that was one of the reasons we did a study like that with a partner like RAND. So what are we actually doing about this at the AMA? Where do we go from here? And it starts with the physician. And as I say that, I almost have to laugh, because that's not where we started. We started looking at all those other issues that we talked about, EHRs, payment, and we sort of ignored the physician. But the more we've been working on our efforts, the more we've been hearing a particular theme. And we had a meeting last week at the AMA with leadership of some of the leading hospital system physician leaders, and they said one of the biggest shortages in healthcare we have today is physician leaders. There's a real shortage of physician leaders. And I know that's probably not the case here in Palm Beach County, but that's what we're hearing across the country. So we're doing an assessment of understanding within the AMA what sort of programs we have, but even across the industry, what kind of training programs we have. And not necessarily for those who want to seek an MBA. There's a lot of great MBA programs for physicians who want to seek C-suite types of careers. But how do we help physicians who have what we're calling episodes of leadership throughout their careers, whether part of a committee, part of a different activity where they need some sort of skill training, because we need more physician leaders. The second thing we're working on outside of that is the practice. And what we've heard, what we saw in our studies, physicians want to spend time with their patients. How can we help practices become more efficient and take away some of those inefficiencies. Now, large health systems are doing this, you hear things like lean and other techniques. But that is very difficult for smaller practices to do. So how do we create the resources for that?